today I'd like to share introduce to us Dr. Fiona Lindo. She is a physician here, works right here in Houston, Texas, quite a gem of a person. She is the medical director of Urogynecology at the Houston Methodist Willowbrook Hospital. And she's also the Associate Fellowship Program Director of Female Pelvic Medicine and Reconstructive Surgery at the Houston Methodist Hospital. She's on faculty as a clinical assistant professor at Texas A&M University School of Medicine at the Houston campus. Now, Dr. Lindo has a focus in international health and has served as OBGYN Global Health Director. She has worked and taught in 15 countries, including Liberia, Ghana, Haiti, India, and Philippines. She is also the Chief Medical Officer and Chair of the Medical Advisory Board for Your Best Pathway to Health, a ministry that provides free healthcare to uninsured people in major cities across the United States. She completed her OBGYN residency at Bridgeport Hospital, Yale University School of Medicine, and continued her fellowship training in urogynecology at Baylor Scott & White, Texas A&M University. She is a graduate of Oakwood University and completed her master's in public health from Loma Linda. She has a passion for each one to have the best quality of life and focuses on promoting health and wellness, encouraging individuals and groups to attain the blessings that God has intended for us all. So with that, I would like to welcome Dr. Fiona M. Lindo. The floor is yours.
Well, good evening, everyone. I am Dr. Fiona Lindo, and I'm so happy to be here. I'm a urogynecologist, also called female pelvic medicine and reconstructive surgeon, and I take care of the pelvic floor. So tonight we're going to take the floor. We're going to look at and see how we can understand pelvic floor disorders and what we can do to make them better. Okay, so let's get started.
Can we increase the volume, Dr. Climbey? I can't hear her.
So what is the pelvic floor? So it's really, if you think of it like a bowl, where it's a set of muscles, and there's bones there that hold the structure. So there's ligaments and nerves that are also part of that. But it really holds some more important organ systems, like your reproductive organs, your uterus, as well as your ovaries. It has the genital urinary tract, which is has your bladder, and it also has your bowels. So all of these are part of the pelvic floor. And the connective tissue really helps to give support to these organs. So your pelvis is like a bowl, and your pelvic floor is basically the system that's holding that support. So we're going to talk today about what are some of the things that can go wrong in the pelvis, and what are those symptoms that you may experience, and then also what are some things that you can do to help. There it goes. So we were talking about the pelvic floor, and there it goes. Okay, so this is a set of muscles, as I mentioned, and ligaments of the connective tissue. And it really helps to hold support for your organs that are in the pelvis, your bowel, your bladder, your uterus, vagina, and rectum. Now, 1 in 3 women experience pelvic floor disorders in their lifetime. And so they're not to be considered a normal part of aging. A lot of times you may have some urinary leakage, or you may feel a little bit of sagging down in the vagina or in your pelvis, and you think, oh, I'm just getting older. That's not the case. And these pelvic floor disorders, they're not normal, and they can be treated with the successful help of a specialist. So we talked about what causes, what are some of the things that occur with the pelvic floor disorder. And as I mentioned, those muscles are weakened. Sometimes there could be a tear of the connective tissue. And this can happen with constipation or other lifting heavy things. Could be even genetics. And you start to have bladder problems or problems with your bowel control, or maybe feeling a bulge or pressure with pelvic organ prolapse, and sometimes even pelvic pain disorders and discomfort with intercourse. And so we talk about some of these risk factors for pelvic floor disorders. And I mentioned definitely age. As you get more wise and sophisticated in age, you can have these issues. Definitely when you're having, if you've had babies, or if you're now menopausal, where you are past that age, you can start to see symptoms. And then lifestyle, as in everything, lifestyle really plays a big factor in pelvic floor disorders. Obesity, diet, when you're lifting heavy things that I mentioned, all of these things can have an effect. And then issues like having chronic constipation. This causes a pressure on the pelvic floor and can cause you to have some loss of support. Chronic straining, or if you have problems with your lungs and have chronic cough, that also elicits a lot of pressure on the pelvic floor and can cause you to have symptoms. So when we look at pelvic floor disorders, when do you start to expect some of these things? Well, I have a timeline here for you. And we're looking at, your time when you're in your 20s and 30s, and then I've broken it down between your 40s and 60s, and then 70s and beyond, the golden years. And so what we find that in your early years, you may have some childbirth injuries. If you've had the vaginal delivery that was used and instruments were used, like forceps, or if you had large tears, you'll find that you can have some symptoms of having urinary incontinence, or you may have loss of bowel control as a result. You may start having symptoms of painful intercourse, or have a bladder pain syndrome. A very common issue is having when you have pelvic floor spasm. And that's really the muscles in the pelvis that really, they get contracted. It's almost like you're having a Charlie horse that you get on your thigh or a knot in your neck. You'd have a Charlie horse in the pelvic floor muscles, and that can cause a lot of pain and discomfort. And another common thing in the younger age is also constipation. And then looking at your perimenopausal, early menopause, 40s to 60s, you may present with having some urinary incontinence, whether it's when you laugh, cough, and sneeze, you're leaking, or maybe you just gotta go, and can't make it to the bathroom. But another symptom is when you have a combination of vaginal dryness, urinary urgency frequency, feeling like you have urge all the time, you can't hold it. Sometimes that's a result, and very commonly it's a result of lack of estrogen. So as you become more wise and sophisticated in age, your ovaries are not making estrogen anymore. And as a result, it causes, your vagina, the bladder, the urethra, that's that tube that drains the urine to the outside, all those areas really love estrogen. And so when it doesn't have it, they start to act up. And you start having symptoms of urgency and frequency, dryness, pain with intercourse. So all those things can happen. And then you also have loss of elasticity of the vaginal mucosa, and that can lead to prolapse and other discomfort. And then we look at the golden years, 70s and on, and you'll see very similarly that you do have the similar symptoms that can be seen in the other groups. But then as you're out of getting your menopausal now, a lot of women will complain of your recurrent urinary tract infections and maybe accidental bowel leakage, because now their muscles are more weak and they're having loss of bowel control. Another common thing that we see is vulvar skin disorders, and typically that's been seen in postmenopausal women. And it's important, if you're having symptoms of itching and burning on the outside of the vulva, that you get that evaluated, because it could be a cancer. So we've talked about what to expect. And what I want to start to talk about now is bladder control. How common is it? Well, here in this country where we're at, 18 million women live with urinary incontinence. And I'm sure the number is very high wherever you are listening from. And while about 40% of women do actually see a physician within a year of their symptoms, most of them have waited at least 1 to 5 years. And then 25% of them have waited even more than 5 years. Very commonly, I have patients who've been suffering with this problem for 25 years or more and just didn't realize that there was actually help for it. So, and a lot of times, these issues, they're embarrassing, they're very personal, they're hard to talk about. And so more than half of patients are just too embarrassed to talk to their physician about this. But I want you to take the floor tonight and realize that, hey, this problem is not something that you should continue to deal with, but seek help and be able to have someone, a specialist, evaluate you and put you on the road to being able to actually take the floor with confidence. And so what I'd like to talk about are the different types of urinary incontinence. There's a common one is stress incontinence, as I mentioned. So you laugh, cough, sneeze, jump up and down, jump on the trampoline, lift things that are heavy, any type of activity. Your urethra, which is a tube that drains the urine to the outside, it bobs up and down and really does not have lots of support. Okay, and usually it's a small volume leakage, but sometimes you can have large volume. Then we have urge urinary incontinence, and that's the incontinence is when you have your bladder and you feel that urge and you're on your way to the bathroom, and just before you get there, an accident happens. The bladder just empties, and that is associated also with nighttime frequency. You're getting that a lot at nighttime, or really large volume leakage. And then, unfortunately, you can have both at the same time, and that we call mixed urinary incontinence. And we're going to talk a little bit later about some things that we can do to help that. But what I want to do is go next to pelvic organ prolapse. How common is that? Well, here in this country, it has a lifetime risk of about 11%. And of course, it increases as you get wise and sophisticated in age. Postmenopausal women, if you've had more than one baby, that's a risk. Being overweight, the use of tobacco or smoking, it affects your connective tissue and causes things to sag more. And chronic lung disease. Remember, as I mentioned earlier, some of these things cause an increase in the pelvic floor and pressure in the pelvic floor, which causes that sagging and bulge. And so some of the symptoms that we talked about, you can have bulging or pressure, a heavy sensation in the vagina, almost feels like something's about to fall out. Sometimes it could be like a ball or you're sitting on something. You may start to have your urine spray because it's changed the trajectory just due to that prolapse. You may have urine leakage with intercourse, or you may have pain with intercourse. And sometimes women will complain of back pain as a result of things kind of pulling down. So there are different types of pelvic organ prolapse. And I have some pictures here. So one is the cystocele or anterior vaginal prolapse. And what that is the bladder has lost the support and is starting to sag down. That happens about a quarter of the 34% of the time patients will complain of that. Then you can also have a rectocele or a posterior vaginal wall prolapse. And that happens when the rectum bulges into the vagina. We see that a lot in patients who have chronic constipation. As that hard stool is pushing down, then it's just kind of pushing that support that should be holding that rectum in place. And then another type of prolapse that we see is apical or uterine prolapse. And that's when the top of the vagina, or if you've had a hysterectomy, or if you haven't had one, the uterus can come down, the womb actually comes down. and can protrude outside. So the good news is that there is treatment, okay? And so really, you can have non-surgical treatment and surgical treatment. And non-surgical treatment would involve strengthening that pelvic floor. A lot of times we use a pelvic floor physical therapist. Yes, I know. You're wondering, what? A pelvic floor physical therapist? We do have a specialist that focuses on the pelvic floor and helps to encourage you and work on strengthening your pelvic floor muscles, but also your core. They do internal and external exercises with you, and there's something that and they teach you, and you can do those exercises at home. And what that does is help to pull up and strengthen up those muscles so they can give better support. What we find is losing weight has a significant effect as well. And other things that we can do to help with pelvic organ prolapse that are non-surgical, they're using devices in the vagina. These are like silicone rings. We also call them pessaries, or vaginal inserts that can be placed in the vagina and hold everything up in place. Now, they don't cure the prolapse, but they really cure the symptoms and help you to have, you basically will not feel the prolapse. And it's something that you can manage on your own. There's surgical treatments, and there's many different procedures that we can use to correct prolapse depending on what type of prolapse you have. And so we can do these through small incisions in the vagina or through small camera keyhole incisions through the abdomen. But really, you need to get evaluated and then discuss what is the best way that your particular issue can be taken care of with your physician. And so we're looking at the treatments for pelvic floor disorders. And we talked about the prolapse, but there's also stress incontinence and urinary urgency incontinence that I want to just briefly touch on, because there's some things that you can do as well to help. So here you can see with stress urinary incontinence, there's lifestyle modification is huge. If you smoke, stop smoking. If you're overweight, start increasing that physical activity and lose weight. In fact, if you lose only 5% of your body weight, you can decrease your urinary incontinence by over 33 to 40%. So that's huge. And I find that women, when they realize that and they start working on their pelvic floor muscles, they really get a lot of great relief from that. We talked about the use of the pelvic floor physical therapist. They will help to work to build up those muscles in the pelvis, and that helps to give support as well. And then a pessary or vaginal insert can also be used for stress incontinence. Remember I said that stress incontinence occurs due to the loss of support underneath that urethra. So having something there to give support is something that can be very helpful. And those are some non-surgical options. Now, surgery can be done. Sometimes we bulk the urethra. That's the tube that drains the urine from the outside, and place some gel there to help make that urethral opening smaller. But also we do use a hammock for support, a surgical procedure, which is a urethral sling, to go underneath that urethra, that tube that drains the urine to the outside. And that gives support. And typically, if you're very active and you have leakage like that, then that's a better option. Looking at OAB, I have those initials there, but that really is urge urinary incontinence or overactive bladder. The symptoms of you gotta go, gotta go, gotta go. And really, this particular incontinence can really be helped significantly by lifestyle change, behavioral modification. What that means really is being aware of what the fluids you're drinking. Bladder irritants such as coffee, tea, soda, artificial sweeteners, even dairy products irritate the wall of the bladder. So if you have an overactive bladder, you have a sensitive bladder. And those things will cause that bladder to be so irritated and cause the bladder to contract down when it's not supposed to. And that's causing that leakage. And so so what we do is we really work with changing the diet, behavioral modifications, and also work with the pelvic floor therapist to kind of retrain the bladder so that your brain is in control of the bladder and not that bladder controlling you. So we do things like timed voiding, or teaching you to do the Kegel muscle squeeze to use with urge suppression, trying to calm down that bladder before you get to the bathroom so that it doesn't go ahead and empty before you make it. If that doesn't work, we do have medications that can work on the wall of the bladder. There are also things like acupuncture needle, which is like a peripheral nerve stimulation that can go on to a small nerve on your foot that can help stimulate. We have the bladder pacemaker that can be used, even Botox in the bladder. But again, these things, the point of me explaining all this to you is the fact that you don't have to suffer with your urinary incontinence. There are some things that can be done to help improve your symptoms and even sometimes cure them. And then lastly, again, we talked about the prolapse treatments. And, again, lifestyle modification is huge. And so that is along with non-surgical options and surgical treatments. Bottom line is you want to try and be evaluated, and so you can get help for that. So, I kind of gave an overview of all of these treatments, and what I'd like to do is just briefly go over some of the common triggers that you may be experiencing. And then I'll be happy to take some questions as well, okay? So just for a wrap up, basically, of what we talked about, urinary incontinence symptoms, if you are leaking, coughing, sneezing with activity, that's stress incontinence. And remember, there are lifestyle modifications such as losing weight and stopping smoking that will help, as well as non-surgical treatments, using that pessary or physical therapy, and then surgical management. Overactive bladder, as a review, because you're going to have a quiz at the end. Overactive bladder, that sudden urge when you have a sudden urge to urinate, it is difficult to get to that bathroom. And as I mentioned, you can see the picture of the bladder there. That bladder, if you have overactive bladder, your bladder can be very irritated. And so you want to remove those bladder irritants. Common triggers, if you are a person who feels the urge to urinate if you hear water running or have your hands underwater, that's a trigger to overactive bladder. Or you just got home and you're trying to get that key in the door, and as you're getting the key in the door, you have leakage. That is a common indicator that you have an overactive bladder. And so typically this is a chronic issue, and we can do things to help reduce the symptoms, and also being able to utilize your pelvic floor muscles is going to be helpful. And we did go over this already, but then again, as a recap, as you can see, there's a common theme here. Lifestyle modification is key. And then again, being aware that there is pelvic floor physical therapy that can help to work with you with your symptoms. And so I encourage you not to live with pelvic floor disorders, but to seek a specialist and get help, because as you can see, there are lots of things that can be done to help. And I'll leave you with this picture. All right.
Okay. Well, Dr. Lindo, I do have a couple of questions, if I may.
Sure.
So thank you. First of all, that was an excellent presentation. It really covered quite a bit of information that is so very practical, and oftentimes women are shy of of even acknowledging that they have these problems, and certainly for seeking medical help. What you mentioned tears. So tears typically perhaps may have occurred during childbearing age, and then the result of them are of the tears are perhaps felt much later on or recognized much later on. Is there hope for those people if they recognize it several years later or decades later? Or is it typically routinely recommended for the pelvic floor therapy as soon as the woman, the physician realizes that she had a 4th-degree tear or whatever degree tear she's had?
Yeah. So typically, it's a very excellent question. Typically, women, we see them later on in age, and they may present, say, with difficulty holding their stool. And then we'll find out, because that's a really big, a 4th-degree tear, just so everyone understands, this is if you've had, during your delivery, you've had a big tear that went through the vagina and through down into the rectum. And typically that's repaired, but sometimes what happens is the muscle that helps to keep you continent is disrupted during that tear. And if that occurs, and even though it's healed, sometimes you can have residual effect as you get older because the nerves that go to that muscle is not working as well. And so there are some things, say if someone presents with loss of stool by accident, typically if it was a tear or injury that was done early on and we've identified that early on, like you present at a younger age, we can try to repair the sphincter. That sphincter muscle could be repaired to help give help with the incontinence. But the other aspect of it, if you present at a later age, we do have something called sacral neural modulation. And what that is a lead that goes down to your nerves in the pelvis and helps to stimulate that nerve to help to control the bowel, loss of bowel by accident. And we've found very good success with doing that. So there is something that can be done. Sometimes we'll complain of just feeling loose and things there from childbirth. Physical therapy is really important to help strengthen that pelvic floor. But if you're postmenopausal, using some vaginal estrogen cream to help bring back elasticity to the vagina. Now, some of you that are out there may say, hey, I've had breast cancer, and they told me that I can't use any vaginal estrogen. And, it's typically if someone has had, an estrogen receptor positive cancer and is in treatment, a lot of times the oncologist would not want you to have any vaginal estrogen cream or have any estrogen. If you're post-treatment and you're away from that diagnosis, using a small amount of vaginal estrogen cream is fine. But there are other things that we can use. There are things like hyaluronic acid. And what that is, it can also work, it's non-hormonal, it can work inside the vagina and around the urethra to help treat that area. But also there's things like DHEA, which is also something that you can ask your physician about to help with treating vaginal dryness. I always encourage people to use lubrication during intercourse. Things like you can find in your kitchen, like coconut oil, or olive oil, or grapeseed oil, or even Crisco. These things can be used in the vagina during intercourse. But even it can help to moisturize the vulva, which is the skin on the outside, and inside the vagina, to keep it soft and prevent the symptoms of dryness of the summer. So I'm sorry, it was a long answer to the question.
Oh, that was excellent. That was excellent. So do these tears, can they cause quote-unquote strictures?
Well, sometimes, typically, you can have some scar tissue. Typically, you don't see that often. If you've had, if you've had obstructive labor and you've had some severe scarring after, that can cause some strictures as well. And so that is something that can happen.
All right, we have a question here. Do men have a pelvic floor?
Men do have a pelvic floor. Good question.
All right. And so if yes, to continue on, can men have pelvic floor disorders?
Yes, they can. Men can. And I'm not a urologist per se. I treat females, but yes, men can definitely have pelvic floor disorders, and they can present with the same symptoms of urinary leakage or incontinence. They may have difficulty emptying their bladder. They may have even loss of bowel control. And so, yes, they can also have those same disorders. And the symptoms can present, they may have difficulty, having dribbling or feeling like their flow has decreased. They could have pain as well. And so typically the treatments, definitely you want to see your urologist to get evaluated. But we also use pelvic floor physical therapy for men as well, significantly in helping to treat those pelvic floor disorders.
All right. And then the last question I have here is prolapse cancer.
Okay. So the question about prolapse and cancer?
Well, some want to ask if I have if I'm experiencing prolapse, is that the same as a cancer?
Okay, very good question. So a lot of times these women will present and they're scared because they just saw this bulge that kind of looks like something like a tumor or what have you. But I reiterate to them, prolapse is not cancer. It will not kill you, and it will not give you a negative outcome. What it does do is can cause you to have symptoms of discomfort. So it is not cancer. And so I just want to reiterate again, prolapse, that bulge is not cancer. It's really your own body's tissues that have lost support and now are kind of bulging out.
Okay.
But excellent question.
Thank you. And I'm not getting any more questions on this end. Dr. Satya, do you have any?
Yes, one came across here. What are some non-surgical ways I can help urinary incontinence at home?
Yes, excellent question.
So I guess they're still concerned of coming to you or to their physician or to the pelvic floor therapist.
Well, especially now in the midst of a pandemic, I can understand why you don't want to come and see.
That's right. Compounded by the COVID fear. Yeah.
Compounded by COVID.
Yes.
So some of the things that you can do, if you were one of those people who had that urge when you hear water running or you're trying to get to the bathroom and you're leaking on the way, definitely do a check of what you're drinking. Because I guarantee you, if you're doing a lot of tea and a lot of soda or coffee, a lot of people like coffee, other parts of the world love to drink their tea. If you're having a lot of that, you will want to cut down on that and even try to eliminate that from your diet. You will notice that your bladder will not be as overactive because those are bladder irritants. Other things you can do is you can actually start to learn how to do a proper Kegel exercise, and that's that pelvic floor squeeze that we talked about, or pelvic floor lift. And how you do that correctly, because really, why I like the physical therapists is because they help to teach you and make sure that you're actually doing that exercise correctly. But typically, when we ask a woman to squeeze, they're actually, bearing down and pushing or squeezing their hands or their face, and they're not really moving their pelvic floor. But what you can do is get a mirror. Place that mirror in front of your perineum, so looking as if you're looking at the vagina, the vulva area. And then you're gonna go ahead and push and bear down like you're having a baby, or bear down like you're having a bowel movement. And you will see that pelvic floor and the vulva pushes open. When you see that, you're gonna do the opposite and try and close that and pull up. And when you see that in the mirror, you'll see that pulling up motion. And then you'll know that you're doing that squeeze correctly. So So you can actually start to teach yourself how to do pelvic floor muscle squeezes, and that's going to be important. Another thing that you can do is that if you get that squeeze going, if you feel that urge right before you feel like you can go to the bathroom, you feel that urge, you're about to get up to go, don't get up. I know you're feeling like if I don't get up, I'm going to lose it. But no, trust me. Don't get up. You're going to take a deep breath and let it out. And then what you're going to do is do that squeeze, that pelvic floor lift. You're going to hold it for 5, 4, 3, 2, 1, and relax. You do it again. You hold it for 5 seconds and relax. Do that 5 times. Let that urge pass. Then you're not going to run to the bathroom like you want to do. You're going to walk slowly to the bathroom. What that is doing is retraining that bladder so that you're in control of it and not the bladder in control of you. So there's those things that you can do at home.
So this could be a lot of it, or maybe to some degree, a mind game.
Absolutely.
The mind controlling the body.
Yes.
And telling it what to do.
Yes, that's right. Try to retrain that bladder so that it can get back in control, under control of the brain. So what's happened is that you're just, when it comes to overactive bladder now, not stress incontinence, but overactive bladder, that bladder has a mind of its own. And you've allowed it to have a mind of its own because as soon as it peaks, thinks it peaks, you're running. And it says, yep, I'm going to go. But really, that bladder should really remain quiet and allow that it to fill with urine. And when it's full, then it should make a pee. So with overactive bladder, it's making a pee when it's not even ready to go. So that's why really doing that kind of behavioral modification and retraining of that bladder is so important. And it's something that you can start to do at home.
Right. Which is excellent. Yeah. And so this actually, there is hope, is what you're saying.
There's always hope.
That
Absolutely.
One can recover from even this so-called 4th degree tear or things like that. Hopefully not everybody sustains that, but there is still hope, regardless of when you identify the problem, to help retrain these muscles and energize them and get back to some normalcy without.
Some people need surgery, but some things can be helped as well with non-surgical options, and that's really with the lifestyle and the behavioral modification and stretching that pelvic floor. Absolutely.
I deal a lot with the elderly, and some of the ladies just say, well, this is my life. This is what I have to deal with. And so what we have learned tonight from you is that there's always hope, that you're not too old to get hope. And of course, with an older population, some of them have, modesty issues and stuff like that. They don't like to talk about these things. But I imagine you have to get to the place where you're willing to say, I'm not going to let this little bladder run my life. I'm going to seek some help. And it might be something as simple as what you just suggested, doing the cable, squeeze or whatever you want to call it, and holding for 5 seconds, and start right there in your living room, retraining that bladder. And so I guess that would be one of the messages that I would carry away from this is, don't prolong the agony. Go ahead and seek some professional help, and it might be something as simple as some exercises that you're taught how to do properly, and there might be some intervention that is required, but that is something that you can discuss with your practitioner.
Absolutely. You hit it right on the nail, Dr. Climbing. Absolutely.
Thank you. Well, Dr. Satya, do you want to wind this up?
Well, Dr. Lindo, this is just superb. Very, very appropriate, timely. I mean, I think it's timely anytime, really. because there's such a large population that is suffering from something like this worldwide. And so it's very, very applicable. Everything you have said is simply so practical and doable. And again, as Dr. Kleine and you put it, there is hope in this message. That is so. I want to thank you for being so spontaneous and so willing to come on board to give us this talk today. I would also like to share with you and the rest of the watching worlds that this will be recorded and played. First of all, posted on the website, Collective Power One International website, or Facebook, one of those, so others can hear it. But also will be recorded so it could be distributed in different parts of the world and reproduced in whatever media that they have access to. And so I want to state how grateful I am to you, because the impact is so global. Just your sacrifice of time, and thank your patients as well for sharing you with us, and your family as well for sharing you with us for this time. And if others have questions, we will take them and we will send them your way if time permits.
I'll be happy to. Thank you so much. It was a pleasure to be here.
Thank you.
Thank you. Have a blessed evening.
Thank you.
There are questions in the chat.
Yes. All right.
Dr. Kleine,
Yes.
there is a Dr. Lindo. So she has stepped away, but we will be having more sessions on this because it is such a common occurrence, as you saw. So we're going to have a team of doctors speak on this, perhaps over a longer period of time. So I don't know exactly what the questions are. Dr. Kleine, do you have access to them?
I just wanted to tell everybody I have the list of your questions.
So
And
if you have more, you jot them down because we will have another conference. But go ahead, Dr. Kleine.
Okay, so I have a list of them. And before Dr. Lindo had to leave, she had an emergency. She was saying that she wanted to do this, perhaps have a whole week on this, because she was very excited about, getting these messages out about women's health. And so unfortunately, we don't have her available right now to answer your questions. But what we will do is we'll let you know when we're going to do this again. And I've already, like I said, I've saved up your question. You've got some great questions out there, and I've saved those, and I will make sure that those are addressed when we delve into this just a little bit deeper, a little more thoroughly. And one of the problems that we have when you're dealing with OB-GYNs is that, those women folk are just out there having babies. And even though somebody may have dedicated or promised that they're going to spend the evening with us, when something happens, they have to leave right away. And that's what happened with Dr. Lindo. So we do appreciate the time that she was able to spend with us.
I can take a few of these questions, I believe. And that is a phone I cannot control. Sorry about that ringing.
All right.
Don't know how to turn that on.
I will go ahead and run these past you, Dr. Kleine, and then you can, if it's something that we have to refer, then we can. But we have one of the questions is, what treatments are available for women who have had partial or full hysterectomies?
Yes, of course, we will present this question to Dr. Lindo and others, the team, but the treatments are, regardless of these surgeries, those symptoms can be treated with the pelvic floor exercises. As a gastroenterologist, as you noticed, one of the diagrams, you can even have rectal prolapse, and then all this feeling of fullness and so on and so forth, or incontinence and so on. So even for that, just those Kegel exercises, and of course, as a gastroenterologist, I was working on the rectal areas, but they're very, very similar. So just for fun, I would tell them to hold a penny in their quote unquote crack. Now, I know all of you are, so be careful. I learned that from my music teacher, believe it or not. She was a 75-year-old elderly Mormon who taught me that. I didn't know what a crack was, but now I do. Anyway, so hold a penny in it and then see how you do it. You can do it while you're sitting, while you're standing, while you're walking, and you'll see the difference in how your abdomen and your pelvis just changes. So the answer is yes. Those exercises are just quite phenomenal. And the pelvic floor therapists, they are able to even train us with a kind of a TENS unit. Some of you may be used to or familiar with a TENS unit. So there is electrical stimulation that is done to help with all of this. And the exercises are phenomenal. Whoever designed all of them are pretty amazing. So I believe the answer is yes, regardless of partial or total hysterectomies.
All right, thank you. And then the next question is, can this issue be caused by the quantity of medication that one is using?
Excellent question. Yes, the answer is yes. So polypharmacy is a cause that one cannot overlook. And so if you look at the PDR or even your prescription, and the pharmacist gives a list of things of what it can do, honestly, they list everything from the head to the toe. And so many neurological drugs, Neurontin, or I don't want to name any of them, but many of them, you're treating it for something else. The side effect is this. So nocturia and all of this, because all your muscles are, or even muscle relaxants for that matter. So they're all relaxed. That includes the pelvic muscle. So that does happen. So again, from a gastroenterologist perspective and somebody who's into wellness and fitness and all of that, the least amount of drug you need, that is most is what you need to be on. So though they say that you need to take it 3 times a day, that's based on the half-life of a drug, you can still minimize the amount of drug you're taking. Okay. And the result of it, it's going to take time. If you took that drug for n number of months, to reverse that may take that much amount of time too. Mm-hmm. So depending on what the drug is and what the damage it did. But again, there's hope that it's reversible, okay. Hopefully.
Now, the next question that we have is, I think we're talking about the therapy that you could be prescribed. And it says, where can you get the therapy? And can this therapeutic session be helpful to men in their 70s and over?
Oh, yes. The answer is a vehement yes. There is therapy for both men and women, and it is therapeutic and it is beneficial. So again, I hope you picked up her specialty is actually urogynecology. So for men, you will need to see a urologist. For women, it'll be a urogynecologist. So urogynecologists focus primarily on that. So again, the pelvic floor therapist and exercises are applicable to both men and women.
Okay. The next question is it true that it takes 4 hours for urine to build up? I'm assuming that means, does it take 4 hours for the bladder to fill?
I guess it's going to depend on the volume of your fluid intake. So, and then a lot of it is mind over matter too. So second, there are other neurological issues sometimes that prevent the sensation of fullness. Just like we had the other syndrome she was mentioning, that even though the bladder wasn't totally full, it seemed like we had to go, and therefore we would run with it as soon as you're opening the door or close the water or whatever. So similarly, that can happen. So how long it takes, I don't know exactly, to be honest with you, but I think it would depend on the amount of fluid you're taking and the types of fluid you're taking. Again, the coffee and the Cokes and the carbonated drinks, etc. she mentioned caused that urgency. So I don't know if I've answered the question,
Right.
but
I think also the efficiency of your kidneys. And
right.
if you got some high grade kidneys there, they might be able to fill that bladder up pretty quick.
Yeah, right.
All right. And then the last question that I have is approximately how long does it take to retrain these muscles?
Also an excellent question, my goodness. Very, very good questions. This again, to begin with, depends on when we identify the problem, how long the problem has been, how chronic of a state it is, in order for us to reverse it. So if you are young and in the childbearing age, if you've had these problems with delivery, you're delivering a very large child, or an infant, or, and you've had any vaginal problems, that's post-operatively is when you should start, technically. That has the highest yield of recovery. As she mentioned, there are surgeries that can fix, if the tear was 4th degree, that tears even the rectal muscle, it's easier to fix earlier on than later on. Then again, it depends on the etiology, or what I mean by that is the cause of this problem. So was this surgical, was this drug induced, or other? So based on that would determine that. Second is how diligently are we actually exercising and taking time to do these movements or all the exercises. So it takes time. So it's building not only your pelvic floor, it's your muscles, and you'll be surprised how many muscles are involved in this pelvis. You move your leg, you move your hip, you're moving your pelvis. You're raising your leg up, you'll notice your abdominal muscles changing position, your hip. I mean, just any number of movements cause that. But the vaginal muscles themselves, we are supposed to be able to train that. And you technically can isolate the rectal muscles versus the vaginal muscles ourselves. So that takes a little practice, I think, or you have to know your body well enough which muscle you're actually activating or stimulating. Yeah.
Well, Doctor, I haven't had any additional questions pop up here. And so I think it's just about time for us to
you're
close
welcome
this
to
down.
Open them all up. All of you can say hi to each other. And
okay.
And
well, yes, we can go ahead and ask everybody.
And I do have to make a quick announcement.
Yes.
So we will have, please join us again next Monday. We are going to have another excellent speaker, and we will be speaking on prostate cancer, the new therapies and new technologies and the new hope for prostate cancer. So bring your hubbies along, and all men and women. Really, both genders have to listen to these things because they are helping support their spouses, or their children. So I think it's very critical that you understand what's happening to your mate or to your. And then Wednesday, we will have another excellent talk, again at 7 o'clock Central Standard Time. And that is going to be on plastic reconstruction of breasts after breast cancer, and some more other things about reconstructive surgery. So excellent speakers. These are very well renowned individuals. So don't miss this opportunity to learn and grow. So do join us again. You will see that on your link. The link is included. You will see the names of the physicians. Many of them, or all three of them, are Houstonians. So those of you who are here in the Houston market, please know that they're right here to help us. And join us for our cancer run. And we will be part of 2 Guinness World Records, believe it or not. Collective Power One International has partnered with our Indian partner called Bridge Gap Hospitals, and they, with their corporate social responsibility wing are doing our cancer awareness run. It's $10 to sign up. Again, we're doing this virtual and it will be international. Right now, we have over several million lives, I believe, that are participating. So be a participant, be a part of the collective. And the second one is the Women's Health and Awareness lesson. And that is also another event that we believe we will attempt for the Guinness World Record, be a part of it as well, learn and receive and be blessed. So 10/10/2020 is the day, but that's going to be in India. So here it'll be Friday night and going into the wee hours of Saturday morning. But please join us and be a winner.